Hey everybody, this is Sarah Kreger. I'm an emergency physician and intensivist at UCLA, and this is the ICU EDU podcast. So this is Valvulopathy Part 2 on stenotic valves. But before we dive into the fascinating topic of valvular stenosis, I wanted to give a quick update on the other project that I'm working on that's going to be going live soon. So one of the reasons that the ICU EDU content has been quite slow for the past year or so is that I've actually been spending most of my free time working on a new educational project that I'm super excited about called Rapid Sequence, which I'm creating with Ryan Ernst, who is EM faculty at University of Utah. So at some point, I realized that me blathering on about all of this stuff that I talk about is probably sort of helpful, or hopefully sort of helpful, but that the only way to actually wrap your head around how to think about complex critically ill patients is to practice doing it. So we've been working on creating this clinical cases web-based game where you have to manage multiple sick patients at a time. And then there's these teaching videos on each case. The full online version is going live this summer, but we are going to debut it as a live workshop in Montreal on May 24th as one of the ISEM pre-conference workshops. And so I have the link to the Rapid Sequence website in the show notes for anybody who's interested in taking a look. So now on to valvulopathies part 2. In part 1 of valvulopathy, we talked about regurgitant valves. We're now going to move on to stenotic valves. So patients with stenotic valves are similarly in a situation where you really have to trust the physiology, because appropriate management requires you to do some seemingly counterintuitive things that you might be hesitant to do unless you've wrapped your head around why you're doing them. The good news here is that, like with regurgitant valves, understanding the physiology pretty directly translates into your management strategy. Now, we're again not going to go into the details of chronic management and surgical decision-making around valve replacements. Instead, we are just going to focus on medical management in patients with severe valvulopathies when they come in acutely sick. The two stenotic valvulopathies we're going to talk about are aortic stenosis and mitral stenosis. We're going to skip tricuspid stenosis because it's extremely rare, and skip pulmonic stenosis because that's mainly associated with congenital heart disease, which is a whole different topic, and one that, while I really wish I could talk about it intelligently, I definitely can't. As opposed to regurgitant valves, where the super sick presentations are often subacute or hyperacute, stenoses are chronic problems. And those patients who present acutely sick with stenosis usually have hit some kind of threshold where the stenosis gets bad enough that the compensatory mechanisms start failing. And these patients are just perpetually sitting close to physiologic collapse. And because these patients have a really limited physiologic reserve and are just not able to mount much of a compensatory response to any given physiologic stress, as we'll talk about below, even a relatively small physiologic stress can make them totally fall apart. In terms of recognizing that a valvular stenosis is a big component precipitating your patient's acute deterioration, it's of course really helpful if they happen to already carry a diagnosis of severe or critical aortic stenosis or severe mitral stenosis. And that's really nice. And if that is the case, then your job is to simply recognize that this may be a significant contributor to their current decompensation instead of just a footnote in their past medical history. Because I think often when we're looking at medical history and when we're looking at their echo report, we kind of, the LVEF is this, and then just kind of, and they have some mitral stenosis. And don't really pay that much attention to, is it just like a little, by the way, incidentaloma in the echo report, or is it like, actually, no, they have severe mitral or aortic stenosis? Now, unfortunately, it's much harder to do a quick and dirty evaluation of stenotic valves on your own bedside ultrasound. But just like with regurgitation, direct evaluation of the valve itself is only one piece of what you're looking for on bedside ultrasound, because even if you can't evaluate that valve directly, you're actually looking for that in the context of a pattern of echo findings that you would expect based on the physiology. So, for example, in aortic stenosis, I am expecting to see in a patient with severe or critical AS a thick, muscular, small volume left ventricle, generally with intact systolic function, and then often you'll see a dilated left atrium as well. In mitral stenosis, you can get some very, very dramatic echo findings that have nothing to do with your ability to directly evaluate the valve. Because in mitral stenosis, you firstly usually see intact or even hyperdynamic left ventricular systolic function, but then you see this massively dilated left atrium. You also have a really dilated right atrium, and your right ventricle is often large and looks pretty unhappy. Now, I'm not really going to get into the details on POCUS for valvulopathy right now, because there's other people who do a much better job of that. And so I'm going to direct you to the same podcast I told you guys about in the first part of valvulopathies, which is the core ultrasound podcast on it, and I will include a link to it in the show notes. Now, there's two other things, clinical context-wise, that will start triggering me to think that I might be dealing with a stenotic valve contributing to my patient's acute deterioration. And the first one is if the patient's hemodynamics completely fall apart when they go into AFib with RVR. A lot of patients don't love being in AFib with RVR, and we talk about sort of unstable AFib, but there's a bunch of patients who, technically they're in unstable AFib because, they're in AFib with RVR and their blood pressure is, sort of 90/40, but they're kind of hanging out and looking okay. Patients with severe mitral stenosis and critical aortic stenosis hate being an AFib. And if they go into AFib with RVR and I suddenly see this patient going from looking kind of okay, like maybe not great, but kind of okay, then they go into AFib with RVR and they try to die and they just start looking awful, that's something that triggers me to think, might I be with a stenotic valve here? Because they just tolerate AFib with RVR so poorly for reasons that we'll talk about in a minute. Another major thing that'll trigger me to think about a severely stenotic valve is when a patient is just way sicker than I would expect them to be based on the level of physiologic stress they're being exposed to. So, if a patient comes in with a little gentle sepsis, just a little bit of bleeding, some relatively minor hypo or hypervolemia, and the infection, the bleeding, the dehydration or hypervolemia just doesn't seem that profound, but yet they're super, super sick. That is another thing that triggers me to be like, okay, is this one of those situations that this patient just cannot tolerate even a minor physiologic stress because their severely stenotic valve is keeping them from using the body's normal compensatory mechanisms? And then, lastly, as with regurgitant valves, if I have a patient who's just acting progressively more shocky, even when I've been giving them appropriate treatment and I'm doing all the right things, but they just keep deteriorating, that is a situation when I really start incorporating the possibility of valvulopathies, including stenotic valves, into my iterative hypothesis testing. Because often in those situations, when I figured out the answer, I've been like, oh yeah, I just hadn't thought about a particular valvulopathy. And also similar to regurgitant valves, patients with stenotic valves require some very specific management strategies that don't necessarily fully overlap with most of the general measures that we would otherwise be using to treat shock. And they will not get better until and unless you initiate the specific management strategy that takes into account their underlying pathophysiology. There's two core principles to understand about the pathophysiology of stenotic valves, and we're going to go through and talk through each one. The two core principles are 1, fixed resistance, and 2, secondary consequences to cardiac anatomy and physiology. So let's start with fixed resistance. This is essentially the exact opposite problem that you get with a regurgitant valve. So as we talked about before, with a regurgitant valve, your physiologic problem is that you've become totally dependent on the upstream to downstream pressure gradient to maintain forward flow. With a stenotic valve, on the other hand, the fact that the valve provides a fixed resistance means that the forward flow becomes increasingly independent of the upstream to downstream pressure gradient. It's now the pressure gradient across the valve that matters here, not the upstream to downstream pressure gradient. And that's just not supposed to be how our circulatory system works. Our valves are supposed to be responsive to upstream to downstream pressure gradients, and as a valve becomes progressively more stenotic, you start losing that relationship. Stenotic valves are also a pathologic situation because most of the resistances in the circulatory system, like the systemic vascular resistance, the pulmonary vascular resistance, are variable rather than fixed. So, your systemic and pulmonary vascular resistance are being constantly readjusted endogenously. They're getting dilated, they're getting constricted, and then of course we can iatrogenically adjust them when we give vasoactive medications. So your circulatory system needs to be able to respond dynamically, and that's why it's designed around more variable resistances rather than fixed resistances. But with a stenotic valve, you now end up with a fixed resistor to forward flow that is not modifiable, short of doing a valve replacement. The second core principle of pathophysiology of stenotic valves is the secondary consequences to cardiac anatomy and physiology. So stenoses are chronic problems. And on the one hand, the good news about a chronic problem is that they develop gradually. And when problems develop gradually, they give your heart time to compensate. The bad news is that the way in which the heart has been forced to compensate then results in problems down the line that start taking on a life of their own. And what it means is that a lot of the issues you're going to run into with these patients by the time they have severe or critical stenoses are in fact the secondary anatomical and physiologic consequences that have developed over time in response to the stenotic valve. So let's talk about how these two core pathophysiologic principles play out specifically in aortic versus mitral stenosis. And let's start with aortic stenosis. Aortic stenosis. Key physiology principle number 1 is now the fixed resistance of the aortic valve. So when you're talking about left ventricular afterload in most patients, what you're talking about is the systemic vascular resistance, which is your main determinant of the downstream pressure. In patients with critical aortic stenosis, however, the afterload that the LV is having to overcome to move blood forward is no longer about the systemic vascular resistance, it's about the aortic valve. So while on first pass, it kind of seems like it would be a good idea to decrease the LV afterload by controlling systemic blood pressure in patients with aortic stenosis, that is not actually the rate-limiting step for moving things forward. Because the pressure the left ventricle needs to generate to open the stenotic aortic valve, it's almost always higher than the pressure it needs to generate to push against the SVR. So your systemic blood pressure, your systemic vascular resistance is no longer your rate-limiting step for forward flow. Our second pathophysiologic principle here, the secondary consequences to cardiac anatomy and physiology. What happens here with aortic stenosis? Well, you end up with a thick, muscular, stiff left ventricle. So the problem here is that the LV compensates for being chronically forced to push against the very, very high resistance of the aortic valve by becoming progressively more hypertrophic. And this means that, on the one hand, your left ventricle is now muscular enough to overcome the resistance of that stenotic valve, but it also means that your LV has become super thick, super stiff, and with a small cavitary, meaning it can only hold a small volume in that small cavity. The major physiologic consequence of this situation is elevated LV filling pressures and increased LV oxygen demand. So elevated LV filling pressures. Generally, patients with critical AS don't actually have systolic dysfunction unless they're very, very end stage, and then you're in big trouble. But what they do have is diastolic dysfunction. That stiff, small volume LV gives you very significant diastolic dysfunction with very, very high left ventricular end diastolic pressures. And the main hemodynamic consequence of this is a very steep left ventricular pressure volume curve. What does that mean? It means that a small change in volume translates into a very large change in pressure. And this relationship happens equally in both directions, meaning a small increase in volume being delivered to the LV can cause a disproportionately huge increase in pressure, which then backs up into the lungs, gives you pulmonary edema, but it happens the other way, where a small decrease in volume being delivered to the LV can cause a disproportionately large drop in pressure, and you start dropping your blood pressures. Other issue that comes up in this context is that tachydysrhythmias start to become a huge problem when you have these high LV filling pressures. Why? Because when your LV EDP, your LV and diastolic pressure, is super elevated, like it is in patients with chronic severe aortic stenosis, you start having issues with diastolic filling. In order to optimize your diastolic filling in this situation, you need time during diastole. Because to get enough blood into that pressurized left ventricle, it just takes more time than it normally does. And the other thing that happens is you become pretty dependent on your atrial kick to push the blood into that left ventricle against that high LV EDP. Now, the fact that sinus heart rates on the slower end of things is helpful is particularly unfortunate, because what happens when you have a chronically elevated LV and diastolic pressure? Well, you get increased left atrial pressures. And now once your left atrial pressures are going up, the left atrium starts stretching and gets really big. And as your left atrium increases in size, that irritates it. And when your atria get irritable, there's a greater chance of developing AFib. But we actually have another problematic physiologic consequence of having such a thick muscular LV, which has to do with left ventricular perfusion. So you have this thick muscular hypertrophic LV. And all that muscle creates increased oxygen demand. And unfortunately, the rate of myocyte hypertrophy exceeds that of capillary angiogenesis, meaning the muscle cells get bigger faster than the capillaries that can provide them with blood. What you end up with is relatively reduced capillary density, and those capillaries are near maximal vasodilation to match that increased metabolic demand of the hypertrophied ventricle at rest. And so at rest, your coronary perfusion is almost maxed out. And so you have no physiologic reserve to fall back on in states of increased oxygen demand. And this is actually one of the other reasons that tachycardia is not great for these patients, because it creates increased oxygen demand. So now you have an LV that is set up for hypoperfusion. And what you don't want to do to that LV is decrease oxygen supply by dropping the MAP and decreasing that already problematic coronary perfusion pressure gradient. And so that's one of the reasons that people get so nervous about giving these patients nitroglycerin or diuresing them, that if you suddenly drop the MAP, they can be in trouble. This need to maintain a solid blood pressure can become a challenge in patients with aortic stenosis, because these patients can no longer rely on some of the normal compensatory mechanisms to maintain their MAP. So normally, your body tries to do two things to support your MAP. One, increase the cardiac output, and two, increase the systemic vascular resistance. So the cardiac output is determined by your stroke volume and heart rate. Now, this is a little bit of a problem for patients with aortic stenosis. Why? Because getting more preload to the left ventricle in order to increase your stroke volume becomes a lot more difficult when you're fighting those high diastolic filling pressures. And increasing your heart rate after a certain point may actually hurt you rather than help you, because once you increase the heart rate, you shorten your diastolic filling time, which is further going to limit the amount of preload you can get into that left ventricle. So what ends up happening is that because there's only a certain extent to which these patients can increase their cardiac output, they become highly dependent on their systemic vascular resistance to maintain their blood pressure. And they don't really have good compensatory options to rely on if their systemic vascular resistance drops. Now let's move on to aortic stenosis management and talk about how all of the pathophysiology we just talked about translates into your management strategy. There are three core components that you need to be thinking about when you're managing these patients. 1, heart rate and rhythm. 2, vasoactives. And 3, volume status. Let's start with heart rate. So tachycardia, as we've talked about in these patients, is bad. And atrial fibrillation is really bad because they need that atrial kick to get blood into the pressurized left ventricle. And so you'll find in some of these patients that if they go into AFib with RVR and you slow them down and they're still in AFib, that's not enough. And you may actually need rhythm control, not just rate control, because that stiff pressurized LV means they really need that atrial kick for diastolic filling. So when they're in AFib with RVR, rate control is good, but if you do manage to slow them down and they're still in AFib, it may not solve your problem, and you need to rhythm convert them even once you've rate controlled them. Vasoactives. So if you need a pressor in these patients, phenylephrine is probably the way to go. And phenylephrine is not my go-to pressor in most situations, but in a patient with severe or critical AS who's hypotensive, that's what I do. So remember that these patients don't generally have problems with systolic function. Their systolic function tends to be intact, so they don't need much inotropy, which is great because in terms of pressors, inotropy and chronotropy usually march together. And as we just talked about, what these patients don't need is a faster heart rate or tachydysrhythmias. What these patients do need is for you to maintain the perfusion gradient for their left ventricle. And since their left ventricle has higher perfusion requirements than a normal left ventricle, and since they can't increase their cardiac output that much, you are really dependent on vasoconstriction, on maintaining that systemic vascular resistance to maintain their systemic blood pressure and LV perfusion. Management strategy number 3, volume status. So whenever I hear someone describe a patient as having a super labile blood pressure, I start to wonder if they have significant diastolic dysfunction. And this is what we talked about with the pathophysiology of that big, stiff, small left ventricle. Because this is when, if you increase the LV preload by a small amount, like by giving a rapid fluid bolus, then that gets translated into a really, really rapidly increasing blood pressure. You get a big change in pressure for a small change in volume. And so your patient will be hypotensive and you're starting pressors and you decide to give a rapid fluid bolus. And then the next thing you know, you walk into the room after you've just given like 250 cc's and now the blood pressure is 180 and the pressors are off and somebody's asking you for nicardipine. Conversely, though, if you drop the volume going to the LV by a small amount, either by diuresis or more often by shifting some of your stressed volume to unstressed volume by vasodilation, you can see a rapid crash in blood pressure. And this is why there's this traditional teaching to avoid things like nitroglycerin in patients with aortic stenosis, because that vasodilation, that sort of sudden, rapid shift of your stressed volume to unstressed volume causes a sudden drop in LV preload. And now you have a sudden drop in blood pressure because a small change in volume translates into a rapid change in pressure in both directions. The same principle holds if you're, say, pushing propofol as an induction agent and you suddenly drop your blood pressures. And so I'm very careful when I'm inducing these patients and giving them anything with a vasodilatory effect or just suddenly taking away their own sympathetic tone to have them on phenylephrine already, because they're just not going to tolerate rapid vasodilation. This whole situation can become especially problematic in our post-cardiac surgery patients, because it's not so great to have the blood pressure suddenly swing up to the 180s in somebody shortly after their aorta were sewn back together. And we often get in this yo-yo cycle. You give a rapid volume bolus because they're hypotensive. Now you're in the 180s. Now you give some nicardipine. Now your blood pressure's in the 60s. Then you turn up the pressors and you're back in the 180s again. And the way to get yourself out is just to go slow, because these guys just don't tolerate fast anything. So in terms of titrating pressors or vasodilators up and down, it's tempting to just, their pressure's in the 60s. Let's go up to 1 on the norepi. And then the next thing you know, you're in the 180s. Or, we're in the 60s. Let's give a liter bolus. Slow, small fluid boluses. If their blood pressure is going up too rapidly, don't wait until you're at the top of the yo-yo before modulating what you're doing. And these are the patients that I won't sort of tell the nurse like, oh yeah, just go ahead and titrate up or down this and give a fluid bolus. I'm standing in the room actively managing their fluids and vasoactives. And the idea is slow and careful. Rapid shifts is not helpful. Slow and steady is the name of the game. Similar with diuresis, in a patient who has a different issue, like say in patients with acute decompensated right ventricular failure, in those guys, giving a big slug of Lasix is often a good strategy and you'll figure out the details later, but not in these patients. Because if these patients start massively putting out fluid, they can rapidly drop their pressure, and that's a decent way to start your yo-yo phenomenon. So aortic stenosis management, heart rate, nice and slow, not an AFib. Vasoactives, phenylephrine your first line, and volume status, slow in either direction. Now let's move on to talking about the physiology and management of mitral stenosis. So mitral stenosis is a lot less common than aortic stenosis, and people with severe mitral stenosis can often be asymptomatic for a long period of time and may not even know, in fact, often don't know, they have mitral stenosis when they present an acute decompensated heart failure. So we have the same basic categories of key pathophysiology that we see in aortic stenosis: fixed resistance and secondary consequences to cardiac anatomy and physiology. But we're now going to talk about how those play out in mitral stenosis. Fixed resistance of the mitral valve. Now, this causes an obstruction to LV filling. And like aortic stenosis, your main issue with forward flow is still LV diastolic filling. And with mitral stenosis, the rate-limiting step for left ventricular diastolic filling now is divorced from the upstream to downstream pressure gradient. So it's no longer about the pressure gradient from the LA to the LV. It has a lot more to do with the increased resistance to transmitral flow. So how LV filling from the LA is supposed to work is that you have a favorable pressure gradient during early diastole that allows the LV to fill with blood until the pressure in the left atrium and the left ventricle equalize. And normally about 75-ish% of ventricular filling occurs due to this pressure gradient. And then your atrial contraction help gets that last 25% or so of left ventricular filling to occur during diastole. But as the fixed resistance of the mitral valve worsens, your LV filling becomes increasingly divorced from the pressure gradient between the LA and LV during diastole. And so this means that LV preload becomes no longer primarily dependent on intravascular volume status. The other thing that happens as the gradient across the mitral valve increases is that you need to give enough time for pressures to equalize. This is the same concept as aortic stenosis, but for a slightly different reason. But having time during diastole is helping you here getting flow across the mitral valve in mitral stenosis. And so just like in aortic stenosis, tachycardia has become really unhelpful. And slow heart rate is better because it gives you sufficient time. Now, in addition to the fact that tachycardias don't help, the left ventricle also becomes increasingly dependent on the atrial kick to fill it with blood, because it's more and more difficult for the pressure gradient between the LA and LV by itself to overcome the resistance of the mitral valve. Because mitral stenosis impairs your normal compensatory response associated with a drop in blood pressure, because like with aortic stenosis, you can't increase your cardiac output, you again become highly dependent on your systemic vascular resistance to maintain blood pressure. Because just like in AS, the valvular resistance provides the impediment to forward flow, not the downstream pressures. And so increasing the SVR is really, really useful, because the biggest problem with regard to forward flow is getting blood to the left ventricle, not getting blood out of the left ventricle. All of the above is one of the reasons why some of the secondary consequences of mitral stenosis to cardiac anatomy and physiology start to become so problematic. So let's now talk about the secondary consequences to cardiac anatomy and physiology you start seeing with mitral stenosis. The first one is a dilated, pressurized left atrium. So mitral stenosis causes an increase in left atrial pressure. And as your left atrial pressure goes up, your left atrial volume goes up, and the left atrium stretches and gets really big. And again, similar to aortic stenosis, as your left atrium blows up, it gets angry and it gets irritated. And when it gets irritated, it likes to develop tachydysrhythmias and atrial fibrillation. And this, again, is extremely inconvenient, because in patients with mitral stenosis, you really, really need that atrial kick to overcome the resistance of the mitral valve and get volume to the left ventricle. And so as such, new onset atrial fibrillation happens often in these patients and may frequently be the precipitant for acute decompensated heart failure. And that's often when these patients present acutely and dramatically. The other secondary consequence of chronic mitral stenosis is type 2 pulmonary hypertension. So this increased left atrial pressure you get with mitral stenosis gets transmitted backwards. So it gets transmitted to the lung and the pulmonary vasculature, resulting in pulmonary edema and eventually type 2 pulmonary hypertension. And type 2 pulmonary hypertension is pulmonary hypertension due to left heart disease, i.e. post-capillary pulmonary hypertension. And if you spend enough time with high PA pressures, that eventually is going to cause your RV to fail because your right ventricle does not like dealing with high pressures. That's not what it's built to do. And just like with any form of pulmonary hypertension, any kind of acute increase in pulmonary pressures can produce acute decompensated RV failure. And what's a major time that you see acute increases in pulmonary vascular resistance from pulmonary vascular constriction? Hypoxemia. And this is also quite unfortunate. Why? Because patients with mitral stenosis can easily develop pulmonary edema as the pressurized LA backs up into the lungs, and then hypoxemia. So like patients with aortic stenosis, patients with MS can no longer rely on most of the normal compensatory mechanisms to maintain their blood pressure. As we talked about, your body tries to do two things to maintain your MAP: increase the cardiac output and the SVR, and you again run into the problem that the degree to which you can dynamically increase the cardiac output in response to increased demand is limited, because you can't just up and increase preload because you have the fixed obstruction to LV filling. And increasing the heart rate may actually hurt you rather than help you, since tachycardia is going to limit LV filling further. So these patients also end up becoming highly dependent on the systemic vascular resistance to maintain their blood pressure and do not have good compensatory options to rely on if this systemic vascular resistance drops. Now, in contrast to aortic stenosis, where you're really dependent on maintaining the MAP for LV perfusion, these guys don't have a thick pressurized left ventricle. So it's less about perfusion and more just about these patients with mitral stenosis just cannot compensate for any kind of acute physiologic stress. Now let's move on to talking about mitral stenosis management. The three core management components that you need to be thinking about in these patients are the same as those in the aortic stenosis patient: heart rate and rhythm, vasoactives, and volume status. Let's start with heart rate. Tachycardia, again here, is bad, and AFib is really bad. And you may need rhythm control, not just rate control, because patients with mitral stenosis desperately need their atrial kick to overcome that fixed resistance of the mitral valve. And so if you manage to slow them down, but they're still in AFib, it may just not solve your problem, and you got to rhythm convert them even once you've rate controlled them. Now, that huge dilated left atrium that puts you at high risk for AFib also means that they have a high risk of left atrial clot formation, even if they don't have AFib. Because more than any other valvulopathy, the patients with mitral stenosis have massive left atriums. And so often these patients are anticoagulated at baseline, because that's the recommendation for patients with severe NS, because they're so high risk for left atrial clot formation. But of course, this can make things really tricky in patients who have chronic mitral stenosis, who are not anticoagulated, or patients with the first presentation of severe mitral stenosis. Because on the one hand, you do want to often rhythm convert them as well as rate control them. On the other hand, you have to keep in mind that if they are not anticoagulated, you actually have to be quite thoughtful about doing it and see if maybe you need to support their hemodynamics some other way, because they're absolutely at high risk for clot formation. So again, there's not always a right answer here, but you have to balance the risks of the hemodynamic deterioration because they're in the rhythm of AFib with the risk of them throwing a clot. Second component of management in these patients is vasoactive management. The goal in a patient with mitral stenosis is to maintain their SVR, because they're really dependent on their SVR to maintain their blood pressure, because their ability to dynamically increase their cardiac output is pretty limited. In addition, since your RV is usually volume and pressure overloaded, it usually has higher oxygen requirements, meaning it needs a solid blood pressure to maintain RV perfusion. Not so much LV perfusion in this case, but RV perfusion in patients with mitral stenosis can be easily compromised because your RV has increased oxygen demand. I will often start with vasopressin in patients with mitral stenosis in order to support my systemic vascular resistance without increasing my pulmonary vascular resistance. In terms of second line, this gets a little tricky. On the one hand, you want to avoid chronotropy because tachycardias and tachydysrhythmias are such a huge problem in patients with mitral stenosis. On the other hand, you usually have a failing right ventricle that could probably use a little bit of inotropic support. Trying to balance those two things, starting norepi as second line is reasonable because it'll give you some degree of inotropy but is less chronotropic than things I would otherwise use for RV support like epi and dobutamine. Milrinone, of course, has the advantage of giving you RV inotropic support without as much chronotropy. But milrinone is also going to give you vasodilation, which is not helpful because you gotta maintain that SVR. And the pulmonary vasodilatory effects of milrinone, or any inhaled pulmonary vasodilator as well, are going to be less helpful here compared to other etiologies of RV failure, because your major problem is the high back pressures being transmitted to the pulmonary vasculature from the pressurized, volume overloaded left side of the heart. Our third component of management is volume status. And this is where you run into the main difference between management of aortic stenosis and mitral stenosis. Because in patients with aortic stenosis, they may need volume because they may need higher filling pressures to help out that LV preload. And in patients with aortic stenosis, you got to be very careful with diuresis. Patients with mitral stenosis, on the other hand, they don't tend to have diastolic dysfunction that the AS patients have, and they almost always need diuresis. These patients are patients that you can diurese aggressively. So, first reason that you often need to diurese them aggressively is that one of the things that really hurts you in terms of the likelihood that the patient's going to go into AFib is atrial stretch. And so if you're massively volume overloaded, your atria are maximally stretched, and you can do anything you want to treat that AFib. You can give amio, you can give MAG, you can give metoprolol. Until you offload that atrial stretch, it's not going to get you anywhere. So in terms of the AFib management, you have to recognize that volume offloading is an important component of AFib management in these patients to decrease atrial stretch. The other reason that volume status and diuresis become really important with these patients is their type 2 pulmonary hypertension and their RV failure. But it's easy to get tricked in these patients if you're doing a bedside echo and mostly paying attention to the LV, because your LV is going to look hyperdynamic and underfilled like it's hurting for preload. And it is hurting for preload. But the key thing to understand here is that while, yes, the main issue with forward flow is indeed filling of the left ventricle during diastole, the rate limiting step for LV diastolic filling is not an insufficient amount of volume in the system. It's all about the resistance to transmitral flow and the failing right ventricle. And so because pulmonary hypertension and eventual right ventricular failure is a major complication of mitral stenosis, you end up with pulmonary edema, pulmonary hypertension, and diuresis is going to help you with all of the above. Now, you can often get into this vicious cycle of hypotension with patients with mitral stenosis if you either don't recognize that mitral stenosis is a big driver of your pathophysiology, or you don't know how to manage it. Because what do we do when somebody comes in hypotensive? Well, we give them a fluid bolus and then we put them in Trendelenburg. Now, if you do that to a patient in mitral stenosis, you're one, going to volume load their right ventricle, which is going to help nothing and make it harder for your RV to push fluid forward. And two, you're going to further blow up your left atrium. And when the left atrium blows up, you're more likely to go into AFib and you're more likely to get tachycardic. And when that happens, now your patient is really going to get hypotensive. What do you do when they get more hypotensive? You give them another fluid bolus and you keep them in Trendelenburg, and you can see how you'd get into a vicious cycle here. Now, this is a situation when you need to give Lasix to a patient who's hypotensive and on pressors. And this seems very counterintuitive. And people often kind of freak out. They're like, we can't possibly give Lasix because the patient is hypotensive. But in this case, what you need to do is give them some vasopressin or phenylephrine to support that systemic vascular resistance to get that blood pressure up, and then recognize that the only way to improve their hemodynamics is offloading the left atrium so that you can get them out of AFib, and then offloading the pressurized right ventricle. And so you start them on some pressors, you give Lasix at the same time. And that's a totally okay thing to do, not just in this situation, but in a number of different situations with a patient in cardiogenic shock. But in this situation, it's often what you have to do. So it seems counterintuitive, but starting them on a vasopressor and a diuretic at the same time makes perfect sense once you understand the pathophysiology. So to sum up valvular stenoses. Stenotic valves are chronic problems, but these patients often present acutely sick because they have no physiologic reserve, and they're sitting perpetually close to the edge of that physiologic cliff, and something, often even a relatively small physiologic stress, can just push them over the edge. The two core pathophysiologic principles of stenotic valves are 1, fixed resistance, and 2, secondary consequences to cardiac anatomy and physiology. So in aortic stenosis, you get fixed resistance of the aortic valve, and in mitral stenosis, you get fixed resistance of the mitral valve. A lot of the problematic physiology that develops in valvular stenoses are, in fact, compensatory mechanisms that the heart develops in response to the chronic stenosis. In the case of aortic stenosis, this translates to a thick, pressurized left ventricle, and in the case of mitral stenosis, this translates into a pressurized, dilated left atrium and associated group 2 pulmonary hypertension. For both AS and MS, the major limitation to forward flow becomes getting adequate LV diastolic filling. In terms of management, aortic stenosis management bottom line, tachycardia is bad and atrial fibrillation is really bad, and so you need to both rate control them and often rhythm convert them. 2, vasoactives. If you need a pressor in these patients, phenylephrine is probably the way to go. You gotta maintain SVR and LV perfusion. And 3, in patients with aortic stenosis, you gotta be slow and careful with shifts in preload. And you often need to give them gentle volume boluses because they need to overcome that high LV-EDP. Mitral stenosis management bottom line. Again, tachycardia is bad and atrial fibrillation is really bad. So you need to rate control them. You need to often rhythm convert them, and you often need to offload the left atrium. You need to shrink it down by getting fluid off of them in order to get them out of AFib. In terms of vasoactives in patients with mitral stenosis, vasopressin is my go-to first line. And then I'll often go to norepi as a second line in an attempt to balance avoiding significant chronotropy while still trying to give the RV at least some degree of inotropic support. 3, diuresis. In terms of volume status, patients with mitral stenosis need diuresis, both to offload the left atrium and help you out with AFib, and also because these patients develop right ventricular failure and you gotta volume offload the right ventricle. So that is valvulopathy part 2, stenotic valves. If you haven't listened to part 1 yet, regurgitant valves, take a listen to that so you can do some compare contrasting with pathophysiology and management. Thanks so much for listening.